Hello, everyone, and welcome to the webinar, Integrating Social Determinants of Health in Health Workforce Education and Service Delivery. My name is Kayla Thompson, and I will be technical support for this event. Before we begin, we'd like to review a few housekeeping notes. First, please note that this webinar is being recorded, and the webinar materials will be made available to attendees after the event. There are two recommended ways to connect to audio today. You can either listen through your computer speakers by using computer audio, or you can use the Call Me feature to receive an automated call from WebEx at no cost to you. To switch your audio connection during the webinar, please click the audio and video button at the top of your screen, then select Switch Audio. All participant lines will be muted for the duration of the webinar, regardless of the audio method chosen. You can participate in today's webinar through submitting all questions and comments to the panelists through the chat feature in WebEx. If it does not open automatically, you can open the chat by clicking the chat icon on the lower right-hand side of your screen. Finally, live captioning is available for this event. Captioning can be toggled on or off at any time by clicking the captioning button on the lower left-hand side of your screen. Please be sure to select everyone in the to field of the chat to ensure all attendees and panelists are able to see your questions and comments today. That is it for my tech notes. At this time, I will pass it over to Kate Greene to get us started. Kate?
Thanks so much, Kayla, and welcome everyone. Bienvenue. We're so excited to have this webinar today, which is part of a series of the Local Health System Sustainability Project, LHSS. It's a USAID flagship initiative in integrating health system strengthening to help low and middle income countries achieve strong, sustainable health systems to support access to universal health coverage. The project is designed to prepare local, public, and private sector partners to implement health system strengthening work independently of external technical assistance, with a goal to transfer at least 20% of USAID funding to local organizations. The project has 3 overall objectives: to increase financial protection, increase population coverage, and increase coverage of quality essential services. Next slide. We're very excited for today's panelists, and I'll explain the agenda as well. My name is Kate Greene. I'm the Senior Technical Advisor for Human Resources for Health at Abt Associates. We also have Dr. Srijana Shrestha, Professor of Pediatrics at Patan Academy of Health Sciences, Björg Paulsdottir at the Training for Health Equity Network, Rachel Marcus, Acting Deputy Director at the USAID Office of Health Systems, Max Eli Arsène Kouassi, Dreams Manager and Adolescent Girls and Young Women Technical Advisor with Save the Children, and Minyote Haile, Project Management Officer with Abt Associates. I will provide more information about their background and expertise as we go through the webinar. I would also like to note that Mr. Kouassi will provide his remarks in French, and I will be providing interpretation during the Q&A session. Next slide. Today's webinar has 3 objectives. We're going to share the results of 2 country case studies, Nepal and Cote d'Ivoire, with an emphasis on the enabling factors to incorporate social determinants of health into health workforce education, training, and service delivery. We'll look at barriers to success encountered by the teams in this work, and also address how stakeholders, including donors and policymakers, can work to integrate social determinants of health into health workforce approaches. Next. These case studies that we're presenting today are part of an overall LHSS activity. We are looking to identify and analyze successful examples of efforts to integrate social determinants of health into health workforce approaches like education, accreditation, and service delivery for improved quality of care and equity in health outcomes. As part of the scope of this activity, we've conducted a literature review, which is available on the LHSS website. We conducted an online survey with respondents from 12 countries to understand what's going on in the field. And we're working on 3 country case studies, Nepal, Cote d'Ivoire, and Eswatini, to document practical models on how to integrate social determinants of health along the health workforce development trajectory. And the focus of today's webinar is on Nepal and Cote d'Ivoire. Next slide. Before we get into the country case studies, we'd like to share with you USAID's vision and how they see the social determinants of health in context of the USAID Health System Strengthening Vision 2030. I'd like to introduce in more depth Rachel Marcus, Acting Director of USAID Office of Health Systems, for these remarks. Rachel is the Acting Deputy Director, and in this role, she serves as an agency expert and coordinator in health system strengthening, overseeing partnerships, policies, and programs to accelerate the achievement of improved quality, equity, and resource optimization in health programs. Rachel previously served as a public health advisor and presidential management fellow in USAID's Office of Population and Reproductive Health, where she managed a range of USAID's flagship global health projects. She has also worked at the Administration for Children and Families at the U.S. Department of Health and Human Services, Marie Stopes International, Global Health Corps, and Women's Project. Welcome, Rachel. Over to you.
Thanks so much, Kate. It's great to be here with everybody today. I'll just run through quickly a few slides. If you can go to the next slide, please. So as Kate said, just to talk briefly to set the stage for social determinants of health in the context of Vision for Health System Strengthening 2030, USAID uses this visual depiction to show the framework for our vision. Helping countries achieve better health outcomes is at the center of USAID investments in health. As you see in the framework, health system building blocks remain important and relevant, but we strive to design health system strengthening activities that impact multiple functions of a health system simultaneously. So we're shifting our focus to health system strengthening activities that promote 3 key health system outcomes: equity, quality, and resource optimization. There are also a set of cross-cutting themes that guide how we program our efforts in health systems. And in the vision, we also have a strong focus on systems thinking and systems practice. Systems thinking is a set of analytic approaches and associated tools that seek to understand how systems function, evolve, behave, and interact with their environments and influence each other. And all of this is relevant for how we incorporate or consider social determinants in our work. This kind of systems practice can help us look for potential health system interventions that are underutilized regarding action on the social determinants of health. For example, one of those cross-cutting themes in the vision is social and behavior change. As we seek to promote lasting change in health systems, it's useful to think about the behaviors that need to change. Behaviors not only of clients served by the system, but also of the managers and providers and other actors within the system itself. Incorporating a systems-oriented and complexity-aware lens to this work helps us to recognize the structural and social determinants of health that drive behaviors and ultimately underpin health inequities, influence quality of care, and influence the efficient and equitable and effective use of resources. Next slide, please. Thinking specifically about the social determinants of health and the health workforce, again, we know that social determinants of health impact healthcare and health outcomes. Social factors and other structural determinants of health inequities, including the socioeconomic and political context, the social status of individuals and groups, affect not only access to, but also the delivery and the outcomes of healthcare. And further, building a more diverse and inclusive workforce is a priority for USAID. So as we consider key interventions to mitigate the effects of social determinants of health, We also know that the health workforce is a cornerstone of a health system's resources and plays a crucial role in reducing inequities and in a whole of society effort to achieve quality. To deliver relevant quality care effectively and equitably, the health workforce, including health professionals, planners, managers, community health workers, must understand the complex factors that influence the health of patients and communities, and they must possess the competencies to mitigate the negative effects of those factors. Next slide, please. So what can we do? Well, I also want to mention that we launched the agency's Health System Strengthening Learning Agenda at the same time as the Health System Vision. The Learning Agenda is one way that we operationalize the continuous learning and adapting aspects of the vision. Learning Agenda implementation is part of how we are capturing the knowledge and evidence that is needed to implement the vision as effectively and meaningfully as possible, and we explore a wide variety of topics and learning. Along those lines, USAID recently funded the literature review conducted by the LHSS project that is being presented and discussed today. And the research is intended to help us understand key themes related to social determinants of health and the health workforce, including what health workforce education approaches support the implementation of social determinants of health, and with what effects for quality of care and health equity for the communities that this health workforce serves. The research also explores what interventions can assist health workers to identify social determinants of health-related barriers and mitigate their effects on quality of care and health equity in medically underserved populations. The literature review found significant gaps related to the integration of social determinants of health into health workforce education, training, standards, and service delivery. And given those gaps, I am therefore so pleased that today we have our wonderful speakers who are joining us to share their experiences leading large-scale programmatic changes that better prepare and support health workers to address social determinants of health as they train and work in their communities. This is a real contribution to our knowledge base and will help others, I think, similarly identify opportunities for action on the social determinants of health. So we look forward to learning with you all today. And Kate, back over to you. Thanks so much.
Thanks so much, Rachel, for setting the context for this webinar and for the case studies. Next slide, please. I'd now like to introduce our next panelists. We have Dr. Srijana Shrestha. Srijana is a professor of pediatrics and former dean of the medical school at Patan Academy of Health Sciences in Nepal. She has expertise in medical education, pediatrics, and clinical research, and served as a member in different national level committees on medical education. She is also a principal investigator and Nepal team lead on several collaborative research activities on vaccine preventable diseases in children. Welcome, Srijana. And we have Björg Paulsdottir, who is the co-founder and CEO of the Training for Health Equity Network, a global partnership of health workforce education institutions committed to reducing health inequities and increasing social accountability. Her areas of expertise are human resources for health, socially accountable health workforce education, and evaluation related to human resources for health. Björg is the technical lead of a working group on equity at the Data and Evidence Hub of the Global Health Workforce Network of the WHO, a member of the Africa-Europe Strategy Group on Health, and she chairs an innovation collaborative at the National Academies of Sciences in the US. First, we'll have Srijana talk about the work of the Patan Academy of Health Sciences in integrating social determinants in health workforce education and give us an overview of that institution. And then Björg will talk about the case study findings. Over to you, Srijana. Next slide.
Kate. So hello, everyone, and greetings from Nepal. So Nepal is a small country in Southeast Asia. It ranks 142nd out of 189 countries in the Human Development Index. The country has poor health indices with a significant gap between different geographical regions, between rural and urban setting, and between different wealth quintiles. So apart from that, there is a huge disparity in the health workforce distribution across the country. So the doctor-physician population ratio is 0.17 per thousand population. However, this number increases disproportionately if we go to the mountain and rural areas. The rurality affects the access and quality, and the social determinants of health drive the rise in NCDs. The country has 21 medical schools, 15 nursing colleges, and 12 colleges with postgraduate public health programs. However, in spite of that, the country still faces a huge shortage in the trained health workers, especially in the government-led primary level health facilities. According to one source, about 60% of the doctors are working in the private sectors, and among those who are working in the public sector, 75% are working at central level hospitals. And again, Nepal is not spared by the global trend of out-migration of trained health workforce, and 40 to 50% of our graduates leave the country. Next slide, please. So in this context, Patan Academy of Health Sciences was established in 2008. It is a non-profit public higher education academic institution, which was established with the main objective or main mission to train and produce competent and committed health professionals to serve the poor and underserved population. And this institution has, the academy has 3 different schools: School of Medicine, School of Nursing, and School of Public Health. The School of Medicine and Nursing has both undergraduate and postgraduate programs, the intake beginning at 2010 and 2016, whereas the School of Public Health has training program for the master's program for public health, and it started intake from 2017. To achieve the goal and the mission of the academy, innovative approaches has been taken on student selection, scholarship schemes, service bonds, curriculum design, and the implementation as well. Next slide, please. So the curriculum of the academy is community engaged and rural oriented. The student gets exposed to the community in several occasions, and they get exposed to the national health system. They have the opportunities to work with the grassroots level health workers as well as the rural health practitioners. They get involved in the community engagement projects, data collection, community diagnosis, and many more. In fact, in one of the posting, when in their first year, the students live with the community in their houses as part of the family member for a week, so that they understand the ground reality of the community. And while in the final year, during their senior clerkship, they spend 6 months in a district level hospital to get exposed to and get training at a low resource setting under a general practitioners. So PAHS works in close partnership with local community and Ministry of Health and Population not only to identify the sites to send the students for teaching learning, but also to select the sites where the graduates will be sent after completion of their training. And so far, we have 6 batches of undergraduate and 3 batches of postgraduate medical students who have completed their courses and been working in different areas of the different parts of the country, including very rural and remote areas. More than 50% of our undergraduates have been posted by the government in the government health facility, especially the primary level health facility of different part, and also the postgraduate trainees are also working in different parts of the country under the government health system. So this is the overall view of Patan Academy of Health Sciences. Thank you.
Next slide.
Yes, hello everyone. I'm Björk and delighted to be here. This was a very exciting and interesting study for us. So as you see here on the screen, the key objectives was to identify with Patan Academy of Health Sciences how stakeholders perceive the social determinants of health and associated competencies, and looking at the steps that Patan Academy has taken in order to integrate that the development of these competencies into their education and training. And the methods that we used is we reviewed curricula, published articles, and other documents, including articles and information from various websites. We also conducted key informant interviews, both with faculty and leaders, both from the medical, nursing, and public health programs, graduates from each of the programs, and supervisors at rural sites, some who were also clinical preceptors. So next slide. So what we found to be enablers, learning from Patan, is the commitment of both leadership and faculty to continue to advocate and for change, and listening and engaging with stakeholders to understand what makes a difference and why integrating the social determinants of health competencies is so important. Another key enabler is the strong relationships that were developed and maintained with different stakeholders, both at nationally or in professional associations, et cetera, but also at the clinical training site and with community groups. And it was certainly very important for faculty leaders to spend time at these rural teaching sites. And interesting sort of learning from PAHS has been the importance of engaging internal stakeholders first, but also regularly engaging with institutional and political leaders to continue to advocate for community engaged learning and social terms of health related approaches. And of course, sharing results and impact. So one of the things that they have done for the faculty to sort of help them internalize the importance of social determinants of health at our regular workshop, and certainly in our interviews, it was very clear that thinking about social determinants of health, it was not sort of seen as a course, but it was really almost a part of the philosophy. Another thing which was an enabler is making sure that you bring in a diverse faculty, and not only in terms of sort of academic topics such as sociology or anthropology, but also from non-governmental organizations, from community groups, and others that bring different perspectives, and again, key also to bring in perspectives from traditionally marginalized groups to help develop the curriculum. Next slide. So the perceived barriers were the fact, and this I think is going to be found in most places, certainly we found that in our literature review, that in general accreditation and professional bodies do not, or at least rather peripherally, consider social determinants of health related competencies as important. So that can be a barrier to integrating another competency into any kind of education. And then of course that the existing rules, standards, and regulations are not designed for community engaged approaches. So when you're an institution with that approach, often you have to first meet the national regulations and standards, but then also to make sure that you're meeting your own goals and measures, you have to evaluate your community engagement and approaches and social terms of health objectives. Clearly, engaging with stakeholders takes time and effort, and challenges are often if there's change in leadership, either institutionally or at government levels, you're constantly having to advocate, and that could slow effort. However, again, PAHS has overcome such barriers by building and sustaining faculty commitment and having very clear outcome measure, as Dr. Shrestha pointed out. It is to address the needs of poor and underserved communities in Nepal. So clearly it is a higher cost if you are engaging in this substantial community engaged learning experience, especially it's in rural area. There's accommodation, transportation, and other things that are much more costly than having a bunch of, students in a classroom. However, it's important to demonstrate the return on investment. And we certainly, not only in this case study, but are finding in other work that increasing the number of graduates, that this kind of approach tends to increase the number of graduates that choose to work in underserved areas. So that certainly is a high return on investment. Another thing is working with partners, both local health authorities, NGOs, and others, where students actually can help provide needed services. And again, that's another way of reducing costs. So next slide. So the key best practices that I think we that we found we could learn from Patan Academy is having a very clear mission and philosophy and desired outcome. If you are having a school that is sort of meeting the needs of the world, it's harder to measure outcomes. But also building on a community and patient-centered approach and a focus on that, using available evidence and promising practices locally and globally. That's what they did. And again, but at the same time, always make sure this is aligned with local needs and context. Again, stakeholder engagement, ongoing, both in designing, implementing, and evaluating programs is important. And the broad range of stakeholders, engaging with everything from health professional bodies, consumer groups, policymakers, health managers, and learners, as well as other experts when you're both designing and thinking about the program. And perhaps most importantly is to engage representatives from marginalized and often, some cases, stigmatized communities to help define the graduate attributes and competencies that are needed for doctors or nurses or graduates to actually meet the needs of these populations. It is important that the curriculum provides much more than sort of a visiting experience, but a real life practical experience of working in underserved and under-resourced areas, and that they get an experience in working at each level of the health system. But also that you focus on not only on technical competencies, but developing competencies that PAHS calls actually non-cognitive, and I'll tell you about that in the next slide. But also make sure you're reviewing the curriculum with stakeholders, including students and communities, to reflect on whether the program is on track and adjusting the program as needed. So next slide. So what we certainly found from this case study was that PAHS graduate provide, the care that they provide is informed by these competencies, both technical, but also their experience and competencies gained from working with and engaging with and listening to folks in underserved communities, and having skills that help them to work with stakeholders, patients, and families to mitigate the negative effects of social determinants of health. And this is improving the care that patients are receiving. And so the competencies I was mentioning that Patan calls non-cognitive are communication related, relationship building, not with patients, families, peers, and other stakeholders, focusing on empathy and passion, teamwork, leadership skills, community mobilization, so which is often perhaps more taught in public health, but this is also something that's taught both in nursing and in medicine, and help them become facilitators in engaging with stakeholders to both identify key problems and solve health-related challenges. And I think one thing that is great that they emphasize is to do that, you applying an asset or strength-based approaches and creativity. And when you get this experience working in underserved communities, but seeing that you can make an impact, I'm sure that contributes to your willingness to go and work there later. Again, so just a couple of examples to mention that what that might look like. For example, these providers, then they spend time, they know that sometimes people are walking 2 or 3 days, or it takes quite a while to get to healthcare facilities. So they take the time, and these are often illiterate, patients. So it's important that the way they communicate, so that patient understand the causes of the health issue, and that the provider understand the potential barriers for adhering to treatment protocols. For example, one of the graduates that we interviewed explained that she actually gave her personal phone number in case they had questions, because, you know, like happens everywhere, you sometimes just think of the questions when you're back home, and they know that this is quite an effort to get to healthcare centers. They also try to understand that cost is a major issue. So as having competency, both understanding the systems and financial constraints of patients, they actually, graduates find ways to minimize the financial burden on the family, which means, for example, calling the insurance or organization to advocate for the patient and prescribing medications that are covered by insurance. So they have a understanding of those challenges. And then quickly, of the 5 cohorts of the PAHS medical graduate, more than 50% are currently working at primary care levels at government health facilities. And like Dr. Shrestha mentioned, that's where there's the greatest lack of health workers. 75% of those are working at the primary level facilities outside the Kathmandu Valley, which is closest to the capital, more central region. And an interesting study, which was focusing on what was happening with graduates during COVID-19 outbreak. It was interesting, even though that these graduates are early in their careers, they were often the lead person in responding, in sort of coordinating COVID responses. Their strength in terms of mobilizing communities, communicating with illiterate populations, or you know, understand the sometimes distrust in health authorities, that made them excellent candidates for designing their response. So they were very often involved in the community engagement, team building, and liaising with government and local authorities. So I'll stop there. Well, I can mention obviously the key indicators for measuring success, and is whether graduates are applying these competencies in their work, and whether programs, research, and interventions are specifically addressing or reflect an understanding of the role of social determinants of health in the community. And as mentioned before, it's quite a new program. So while evaluations are underway, we, as of yet, don't have any large studies. So these were some of our great findings. So thank you.
Thank you, Björg. Thank you, Srijana. Next slide. That was a great window into how the Patan Academy is integrating social determinants of health into pre-service training. And now we'll turn to an example of how in Cote d'Ivoire, a team is integrating social determinants of health into HRH approaches in service delivery. I'm so pleased to introduce our 2 speakers for this case study, Kwasi Max Eli Arsene, who is a technical advisor for issues related to adolescent girls and young women, and manages the DREAMS initiative at Save the Children in Cote d'Ivoire. His expertise includes project management, training, advocacy, community mobilization, and various approaches centered on promoting human rights. He is the co-author of the booklet, Sexual and Reproductive Health, I'm Interested, published by Save the Children Cote d'Ivoire. And after Kwasi describes an overview of the DREAMS initiative, Mignote Haile will speak about the case study findings. She is a project management officer at Abt Associates with experience in health system strengthening, qualitative research, and program management. She works on activities focused on human resources for health, social determinants of health, quality improvement, and monitoring, evaluation, and learning. Kwasi will provide his remarks in French, although the slides will be in English. Kwasi, je vous passe la parole. Next slide. Kwasi, vous êtes là? Voilà.
Nous allons commencer notre présentation. Donc, merci à Kate et bonjour à tous et à toutes. Nous allons démarrer notre présentation avec la présentation du contexte en Côte d'Ivoire. Il faut dire que la Côte d'Ivoire est en Afrique de l'Ouest et nous sommes le premier pays très infecté au VIH, donc à forte prévalence au VIH, et nous sommes à 2,1% actuellement. Et il faut dire qu'en Côte d'Ivoire aussi, le VIH est très loin le facteur le plus élevé de mortalité chez les enfants et chez les adolescents. Et il faut dire aussi qu'à ce jour, nous avons 340 000 orphelins dont l'âge est compris de 0 à 17 ans d'après une étude faite en 2020. Et aussi, nous notons qu'en Côte d'Ivoire, les adolescentes et les jeunes femmes ont un grand besoin en matière de services offerts dans les centres de santé. Next slide. Et c'est en réponse à cela que depuis 2017, nous menons une initiative dénommée Dreams. Et cette initiative-là est intégrée dans le projet Rêve, voilà, financé par USAID. Et il faut dire que dans le cadre de cette initiative-là, nous identifions dans les centres de santé, dans notre zone d'intervention, des points focaux. Donc, ces personnes que nous identifions dans les centres de santé aident nos filles à pouvoir bénéficier correctement des services. Et ces adolescentes et jeunes femmes avec lesquelles nous travaillons, il faut dire que nous les identifions dans la communauté et nous sommes censés recruter les filles les plus vulnérables à qui nous donnons des informations sur l'éducation sexuelle complète pour leur permettre non seulement de connaître leur corps, mais d'avoir des comportements responsables en matière de sexualité. Au niveau 2, nous identifions chez ces filles-là leurs besoins en termes de santé, en termes d'autonomisation financière et autres, et nous apportons les réponses à ces besoins-là. Et au niveau 3, il faut dire que nous impliquons aussi non seulement les parents de ces adolescentes et jeunes femmes, mais nous impliquons aussi les membres de la communauté pour que ces personnes-là, une fois engagées, nous aident à pouvoir corriger ou améliorer les normes des gens néfastes dans leur communauté. Donc, voici un peu. Et parmi ces membres de la communauté-là, nous notons aussi bien les guides religieux et les membres j'allais dire aussi les guides religieux, les responsables d'associations. Voilà. Donc, voici des personnes et les conjoints même de ces adolescentes-là aussi. Ce sont ces personnes-là que nous intégrons dans notre projet pour que cela puisse nous permettre de faciliter l'accès de nos filles aux différents services. Voilà. Kate, merci. Voici un peu ce que je voulais partager sur notre initiative.
Great. Thank you. Next slide.
Thanks, Kwasi. So with that background in mind, I would like now to pivot us to the LHS's case study that focused on the engagement of health workforce aspect of the DREAMS program in the context of integrating social determinants of health in service delivery. The objectives and methods you see on the slides are very similar to the ones, to the Nepal ones we just covered, except for the focus on the service delivery as opposed to the HRH education. So I won't spend a lot of time here. Next slide, please. The Cote d'Ivoire case study found a number of key enablers that have helped the DREAMS program incorporate social determinants of health elements in HIV prevention services. The first one is the holistic and multi-sectoral nature of the interventions. We found out during the case study interviews that the layered interventions were able to account for several social determinants that have impacts on HIV risk, such as socioeconomic status, educational attainment, access to health services and social protection, as well as family dynamics and school practices. This has led to engaging and working with key actors that are able to influence those complex and multi-sectoral variables. And this included actors such as parents, health workers, peer groups, community leaders, school administrators, as well as policymakers. The second enabler is specific to service provision and highlights the importance of actively engaging healthcare providers to bring social determinants of health front and center in their practice. and make sure that they know of existing social services and support systems. This equips them to conduct a sort of a social diagnosis in their routine clinical practice and are able to aid their clients in navigating social challenges and make appropriate referrals to be able to address social aspects that would ultimately impact health outcomes. Under DREAMS, this is facilitated by periodic meetings between the program and health facilities where they share information and coordinate on service delivery and follow-up issues. An important point here is that the health facilities actually serve as entry points into DREAMS because health workers refer potentially at-risk clients to the program, thereby reducing missed opportunities to address social determinants of health-related barriers. The third factor is also closely linked to this. As part of their programming, DREAMS recruits and trains women from within the communities to serve as mentors to the adolescent girls and young women. These mentors lead the screening and enrollment of DREAMS participants. They also mostly accompany the young girls to health facilities and work closely with the care providers to facilitate HIV testing, family planning, and other preventive services, while also cultivating trust with the young girls as part of their regular social circle and building relationships through household and community engagement efforts. So this role, this intermediary role, has contributed to a stronger community-facility linkage and a more responsive and youth-friendly care provision and interpersonal counseling. And finally, the last enabler that came up from the interviews is linkage and involvement of government counterparts. As an example, DREAMS is part of a coordinating platform for HIV response managed by the National Program for Care of Orphans and Children Made Vulnerable by HIV/AIDS. The program also works with Cote d'Ivoire's Directorate of Literacy and Non-Formal Education to facilitate the integration of participants back into formal education systems or enroll them in trades training based on unique needs and individual situations. Next slide, please. The interviews were also highlighted some key challenges related with integration of social determinants of health at service delivery points. The first one is cost of services. Interviewees noted that the most vulnerable adolescent girls and young women at times are still unable to access essential services such as pre-exposure prophylaxis and modern methods of contraception because of inability to pay for those services. When DREAMS initially enrolls participants, socioeconomic status is part of the criteria, but this challenge really highlights ensuring that the broader systems and structures are set up in a way that the most at risk are able to get past financial barriers to access appropriate care at the appropriate time. The second barrier is the gap between increased demand for certain services due to social determinants of health-oriented interventions and sensitizations, and the limited capacity at the facility level in terms of drugs, skilled workforce, etc. This again goes back to a broader systems level challenge in promoting equitable provision of services by addressing social determinants of health. The other barrier is lack of formal integration of the social determinants of health related tasks into health workforce management and evaluation processes. These tasks are added on to a very full and already busy routines of the providers at the health facilities, and the lack of formal integration presents a sustainability challenge in being able to continue to effectively leverage health facilities in addressing and tackling social determinants of health. Formal integration into health workforce management systems and establishing clear incentives would also facilitate a standardized approach to training practices and supportive supervision that will eventually enable a better or more effective and sustainable practice of a social determinants of health aware clinical practice. And finally, another majorly cited barriers were the deeply embedded cultural norms and taboos that could be particularly difficult in the HIV space. Taboos related to accessing health facilities through a program that is known for working on HIV, as well as general reluctance to openly discuss sexual health and history were reported to present quite a lot of difficulties in being able to target and follow up with some at-risk youth. However, the interviews did note that this is slowly starting to shift. Next slide, please. So whilst navigating these challenges, DREAMS has seen success in metrics related to HIV prevention, as well as other social and financial services they aim to comprehensively address. Some illustrative results that were reported during the case study interviews include increased financial autonomy among participants through increased finances and financial assets. For example, over 6,000 young girls and women have been able to set up savings and credit associations for a total savings of over $50,000 US. There has also been an increase in educational attainment, with over 3,600 girls and young women benefiting from the literacy program that is offered through the initiative. Access to care and essential services such as pre-exposure prophylaxis has also increased, which has ultimately led to reduced new HIV cases in the program catchment areas. Thank you all for your attention. I'm going to stop here and hand it back to Kate.
Thank you, Mignote, and thank you, Kouassi. I'd like to ask everyone if they have questions, so please put it in the chat, and we'll be monitoring the chat for this Q&A session. I'd like to start off with a question for Srijana and Kouassi. And that is that I've noticed in terms of the challenges for Nepal and Cote d'Ivoire that there's still work to be done in terms of integrating these approaches into other components of the health system. So for example, for Nepal, the accreditation system doesn't yet recognize these competencies. And in Cote d'Ivoire, the human resources management system or performance evaluation may not reflect the work that health workers are doing for DREAMS. So Srijana and Kouassi, I'd like to ask what your recommendations are for next steps to further integrate these approaches into the health system. And I'm going to pause and translate for Kouassi. Kouassi, c'est une question pour vous et Srijana. J'ai fait l'observation que l'intégration de ces approches dans les autres composantes du système de la santé n'est pas encore fait. Par exemple, à Népal, le système de l'agrément n'a pas les compétences des déterminants sociaux de la santé là-dedans. Et à la Côte d'Ivoire, les compétences et l'effort que les effectifs font pour l'activité DREAMS, de ce que je comprends, ne font pas partie de leur évaluation de performance ou système de supervision. Donc, ma question, c'est quelles sont les prochaines étapes pour l'intégration de ces approches dans le système de santé. Et je vais commencer avec Srijana. Srijana, over to you.
Thank you, Kate, for the question. Yes, you are very right that there's still a lot to be done, but this what PAHS has done, it has been appreciated by the ministry as well as by the Medical Education Commission, yes, but it's still not in the accreditation system. But we have been constantly advocating for that. And since when we started, we had started a different selection process just to make sure that the people who are from the rural background, who do not have a good, who do not get a chance to study in a good schools, just to not let them be disadvantaged, we had a different exam system. And we also used the social inclusion matrix, which gave an extra marks in addition to the score of the entrance exam for those who are from the disadvantaged population from rural areas and that. And since 2020 in Nepal, there is a common national entrance examination. So with that, we haven't been able to use our exam system, but because of our advocacy, a small percentage of the common entrance examination also has the test that we use to perform, like mental agility test, which examines the fluid intelligence of a student and which is not affected by the training or the educational opportunities. So even if there hasn't been much of these kind of tests in the national exam, but because we have been advocating, a small percentage of the exam contains this mental agility test. And as I said, that the social inclusion matrix we had used is not as used in the same format, but the government also has a system which gives some reservation for people from a disadvantaged area. So in this way, we have been trying to advocate for the things that has to be done to improve this huge gap in the country. And similarly, the government is now trying to make sure that each medical school, as part of their social responsibility, will take 1 or 2 districts and to improve the health system there. It is there in the paper, and the government is trying to advocate, implement that. So I'm very hopeful that it will happen. It will take time, but it will happen slowly, and the advocacy we need to continue. Thank you.
Thanks, Srijana. Kwasi, avez-vous des commentaires par rapport à comment bien intégrer le projet DREAMS dans le système de santé?
Ok, merci Kate. Il faut dire qu'à ce niveau, les choses sont en train d'évoluer en Côte d'Ivoire. Déjà, il faut dire dans nos zones d'intervention, nous avons des centres de santé dédiés aux adolescents et jeunes. Donc, dans ces centres de santé-là, il faut dire que les adolescentes et jeunes filles peuvent déjà aller là-bas pour leur service. Et il y a autre chose aussi, il y a que cette année, déjà au niveau du ministère, la PrEP, par exemple, fait partie des critères d'évaluation, de la checklist d'évaluation des centres de santé. Il faut dire que cela est parti aussi des actions de DREAMS, parce que nous avons fait du plaidoyer, nous avons tapé à la porte et haut du ministère, et les gens ont pu comprendre aujourd'hui que bien que la PrEP soit venue en Côte d'Ivoire il y a moins de 5 ans, mais les gens ont pu comprendre que nos adolescentes et jeunes filles méritent aussi d'avoir ce service-là pour se prévenir du VIH. Donc, juste pour dire qu'il y a des avancées, il y a aussi l'opportunité de la couverture maladie universelle que nous sommes en train de scruter parce que nos filles étant vulnérables, elles n'ont pas les moyens. Donc, nous sommes en train de scruter cette assurance-là pour que nos filles puissent non seulement avoir les services appropriés, mais les services à moindre coût aussi. Voilà. Merci.
Thanks so much, Kwasi. And just to summarize your remarks in English, you said that already in Cote d'Ivoire, there are health centers that are dedicated to serving the needs of adolescent girls and young women. And the Ministry of Health has now incorporated PrEP and access to PrEP as part of the evaluation of the health centers themselves and what they're required to do. The DREAMS program has conducted a lot of advocacy for PrEP. It's been available for less than 5 years in Cote d'Ivoire, and the team is committed to making sure that adolescent girls and young women have access to it. And finally, this is all within the reforms in the country to move towards UHC, universal health coverage, and to make sure that adolescent girls and young women are part of that push and are not left behind. We have a question for Dr. Shrestha. Srijana, could you please provide some examples of the health worker competencies for social determinants of health and how these were integrated into the curriculum?
So regarding the social, the competencies, so I would start with an example, like when the students are in their first year, they are assigned some patients with chronic diseases, and then with a differently abled child, and later with a chronically ill or terminally ill patients. And the students will go for the home visit, and they will meet the family and understand all the social determinants of health that is affecting the family, because this will be in the very first year when the students won't even know much about medicine. So they will just go there every week for 6 months to learn about what, how, and what are the different determinants of health that is affecting the whole family. So this is one of the examples they begin with. And the competencies that we want them to know is how, they will communicate with the family. They'll try to understand what are the important social determinants of health that affects the family. So after that, they will write a log, a reflective log on the patient, and this will be evaluated during their oral exam. And this is one of the examples. Similarly, when they are in the community, as I said, there'll be different occasions they'll be in the community, and they will be collecting data on the social determinants of health, and they will be presenting these data to the community. They will observe they will find out the observed needs in the community, and they will make a presentation and present it to the community itself. All these presentations and reports will be evaluated as part of their competencies regarding social determinants of health. So these are some of the examples.
Thank you so much, Srijana. We are almost at time. I do want to note that we will be sharing resources and the final versions of the case studies and literature review from this LHSS activity. So please stay tuned on social media and our project website to look for that. I appreciate everyone participating today and tuning in. And we will work on a recording and slides to share with everyone soon. Thanks so much. And a big thank you to our presenters today.